Assalamu alaikum. Medialisation thyroplasty is increasingly being employed as the first choice in the management of persistent glottic insufficiency, particularly with unilateral vocal fold palsy. This is a section of the thyroid cartilage at the level of the anterior commissure and the vocal folds, showing the vocal folds, the paraglottic space with the thyroarytenoidus, the vocalis part of the thyroarytenoidus muscle, and the thyroid cartilage in the outside. The traditional way of management of glottic insufficiency with a persistent glottic gap during phonation was injection into the vocal fold itself or just lateral to it. There were issues and limitations to the use of this technique, particularly because it may alter the biophysical properties of the very delicate vocal fold structure. And once an injection has been done, you cannot retrieve it back easily, and it can cause granulations. And there is a shift to use laryngeal framework surgery rather than injection into the vocal fold. Laryngeal framework surgery is a family of different procedures changing the framework of the larynx itself without acting directly on the vocal folds. And by doing this, you can change the length of the vocal fold, you can change its stretch, its stiffness, or you can medialize it or lateralize it or change its level. The most common of these procedures and the simplest is the medialization procedure, in which a small window is made in the thyroid ala cartilage, and through this window an implant will be inserted surgically to push the paraglottic space and the vocal fold medially and close up a glottic gap and manage a glottal insufficiency. And it has several advantages that will be discussed. It's becoming increasingly the dominant treatment modality for dysphonia associated with unilateral vocal fold palsy. The most common indication for this procedure is glottic insufficiency from unilateral vocal fold palsy that is not expected to improve. But it can also be employed in other things like prisma laryngeus, or for example sulcus glottidis, or vocal fold bowing or atrophy. It's particularly useful in cases of vocal fold palsy if there is a degree of dysphagia or aspiration associated with the vocal fold disability. It's also more useful when the glottic gap is more than 2 millimeters or so. This type of mid-glottal gap would be best managed by this procedure. The advantages are plenty. It's precise, predictable, and durable. It's also adjustable. You can increase and decrease the amount of medialization depending on visualization of the larynx and on patient's voice. It's permanent, but can be surgically reversible if needed, although there is no much need to remove the implant even if the vocal fold functions returns. It improves glottic closure during phonation and is excellent at closing anterior and mid-glottic gaps. It's the posterior gaps that would usually be persistent after this type of surgery. It can restore the mucosal wave then, and it can be performed under a local anesthetic and can be combined with other laryngeal framework procedures like arytenoid adduction procedures or cricothyroid plication, for example. But it has its own limitations. It's a little bit more invasive than vocal fold injection under local anesthesia, for example. But the main problem with this operation is posterior glottic gaps, particularly with arytenoid instability. This type of problem is not addressed well with type 1 thyroplasty. You need to do other procedures like arytenoid adduction procedures or use a special implant with a large posterior flange to help in sorting out a posterior glottic gap. The skin markings are for the thyroid notch and the inferior border of the thyroid. In between is horizontal skin crease. Incision would be extended for about 7 centimeters through platysma, exposure of the strap muscles, retraction of the sternohyoid, and division of the thyrohyoid muscle with exposure of the thyroid ala here. External perichondrium would be cleared and the window would be fashioned in the thyroid cartilage. It's best performed under local anesthesia so that you can gain feedback about the patient's voice, which from this feedback the prosthesis size and position can be adjusted. The ipsilateral thyroid cartilage is exposed. The most critical anatomic task in this procedure is placing the window in the ipsilateral thyroid ala in the right position with the right dimensions. You don't need it higher than midpoint of the thyroid ala, otherwise the prosthesis could actually medialize the laryngeal ventricle or the ventricular fold. You don't want it too much caudally, otherwise you risk fracturing of this small strut of cartilage. You don't want it too anterior, otherwise it will obliterate the anterior commissure area and the anterior 5 or 6 millimeters of the vocal folds. You don't want it too posterior, otherwise you would actually expose the arytenoid cartilage here, and just posterior to it will be the Pyriform fossa mucosa, and you risk perforation, the hypopharyngeal mucosa, or extrusion of the prosthesis. So you need to get this window with the right dimensions exactly in the right position. The distance from the bottom of the thyroid notch to the lower edge of the thyroid cartilage is just less than 24 millimeters or so. A midpoint here would have 12 millimeters above it and 12 millimeters below it, would usually mark the position of the anterior commissure. This is the first surface landmark. In females, it may be a little bit higher, but then in females, this 24 millimeters distance may be actually about 20 or even less millimeters. From this point of the anterior commissure, a line, an axial horizontal line parallel to the lower edge of the thyroid cartilage will be extended until it meets the oblique line of the thyroid cartilage, where the sternothyroid is inserted and the thyrohyoid originates. This oblique line of the thyroid is the second important surgical landmark. The window should never extend posterior to this oblique line, otherwise you risk perforating the hypopharyngeal, the Pyriform fossa mucosa, which lies posterior to the oblique line, or displacing the arytenoid cartilage. And from this line, 6 millimeters, you drop 6 millimeters vertically, and this will get you to the second line where you would place the end of the window. This would leave about 5 or 6 millimeters strut of cartilage. This is necessary because if you have a cartilage strut at this area below the window less than, say, 3 or 4 millimeters, there is a possibility of having a fracture during the prosthesis insertion. The anterior edge of the window should never come too close to the anterior commissure. Leave about 8 to 12 millimeters from there. The posterior part of the window should never be posterior to the oblique line. So the length of the window itself may be about 12 millimeters plus or minus. So once the window has been marked on the thyroid cartilage, you can use a diathermy to cut into the cartilage itself, or use a knife in younger subjects. And then this cartilage here would need to be drilled. You may start with a large drill, maybe 4 or 5 millimeters, and then use a smaller burr at the end to sort of clean up the corners. The drilled out thyroid cartilage, which may be partially ossified, would show the inner perichondrium in here, and once the hemostasis has been achieved by bipolar diathermy, you would need to lift up this perichondrium from the corners of the around the window. This is usually done with a Freer's elevator or a perichondrial elevator. Note that anteriorly we've left about 8 to 10 millimeters, and inferiorly we've left a strut of about 5 or 6 millimeters. We've not crossed the oblique line and of the thyroid cartilage, and we have not crossed the mid-horizontal line as well. Once the inner perichondrium of the thyroid cartilage is exposed, it should be undermined all around for about 2 to 4 millimeters, particularly posteriorly and inferiorly. Many surgeons would incise into the inner perichondrium to allow an easier medialization by the prosthesis of the paraglottic space, including the thyroarytenoidus muscle. Some would argue that if the inner perichondrium is intact, the medialization, there would be enough stiffness in the paraglottic structure to prevent a very adequate medialization. And those who chooses to incise the inner perichondrium had showed very satisfactory results, but perhaps also more importantly, a very low extrusion rate. So there is no much harm reported about incising the inner perichondrium. The prosthesis would be fashioned according to individual cases after measuring of the glottic gap and taking laryngeal dimensions into account. The posterior part of the prosthesis would be much wider than the anterior part, which may be angled to avoid medializing the anterior part of the vocal fold too much and obliterating the anterior commissure area. This is usually about 7 millimeters or so, and the anterior part would be just 2 to 3 millimeters. The prosthesis would be made with a smaller base area here, which would project from the thyroid cartilage window to stabilize the prosthesis in place, avoid any sliding or rocking of the prosthesis. The dimensions that can be carved from a silastic block would be the base. This small base here would be about 12 millimeters or so. After this, you would make the cut bilaterally for about 2 millimeters and discard with these two red squares. The actual base of the prosthesis would be this, and it should measure something like 15 or 16 millimeters, varies from one patient to another. But this distance would be about 15 to 16 millimeters. The posterior part here would be 6 or 7 millimeters, and the anterior part here will be 2 to 3 millimeters, and it may point to an angle with 1 millimeter or so. These are the dimensions of the prosthesis. Now the prosthesis is made and it is inserted into the window in the thyroid cartilage. It's a bit fiddly at this stage to position the prosthesis exactly where it should lie, and you would be listening to the patient's voice and also gaining feedback from inspecting the larynx during adduction by flexible fibro-optic endoscope. And then refining of the dimensions of the prosthesis can be made. You can cut up a few millimeters from posterior or anterior according to the dimensions of the larynx of the patient and place the prosthesis securely in situ after this. There are other variants to the classic prosthesis. You could have a prosthesis with a very long posterior flange in an attempt to medialize a displaced arytenoid a little bit. It's not very successful because all what it does is just pushing the arytenoid a little bit medially, whereas it should actually be pushing the arytenoids posteriorly and medially to stretch the vocal fold. But that's one modification to the classic prosthesis. The other modification is, rather than using the silastic block, you could actually be packing up the pocket in the thyroid cartilage and the paraglottic space with Gore-Tex. Just pack Gore-Tex into Gore-Tex strip into this pocket in here and watch for the medialization of the vocal fold by flexible endoscopy and listening to the patient's voice. And from this feedback, you could either add more packing or you could withdraw a little bit of the strip. Once the prosthesis is in situ, you can secure it in place with non-absorbable sutures, and then the strap muscles will be reconnected. This is important in all laryngeal framework surgery, to reconnect the strap muscles to help in correct positioning of the larynx and the neck. The skin incision itself will be closed in 2 layers, airtight closure to have suction drainage in place. The most serious complication of thyroplasty type 1 is airway obstruction or compromise and perforation into the laryngeal lumen by the thyroplasty prosthesis. The medialization procedure itself narrows the airway, and if this is combined with some postoperative edema and possibly hematoma, there may be an airway compromise. This is the reason some surgeons prefer to observe the patients in the hospital for a night after the procedure. Very rarely the patient who had this type of operation may require either intubation or emergency tracheostomy if there is serious airway obstruction. If there is a perforation of the laryngeal mucosa by the prosthesis, it would need to be retrieved because of the likelihood of infection and subsequent extrusion of the implanted material into the airway. But the most common complication is this, a suboptimal voice outcome. And this is usually due to technical factor. The revision rates for this procedure varies between somewhere around 5% to 14%. In few reports, it was as high as 1 in 3 patients required a revision procedure or a certain other procedure like fat injections, or for example. The common causes for this poor voice outcome would be a persistent posterior glottic gap, because this type of operation does not address posterior gap very well. But also implant malposition is important. You could see here the silastic block is actually being placed a little bit superiorly than it should, and it's pushing the ventricular band and the ventricle, so there is no good level match between the vocal folds, the 2 vocal folds. Or you can have under medialization if the size of the prosthesis is not adequate, or you can have extrusion or displacement of the prosthesis in other directions, and a small chance of having an infection. This is an example of a misplaced prosthesis in the laryngeal ventricle. Same here, you have the prosthesis actually placed medial to the ventricular band, which now covers the vocal fold, and you can actually see a glottic gap underneath the pushed and medialized ventricular band. Or you could have a persistent mid-glottic gap here if there is a smaller prosthesis than it should, or you could have a posterior glottic gap here, which is not uncommon after this type of operation if the initial cause for the paralysis was a high vagal paralysis. By this, we come to the end of this presentation on medialization thyroplasty type 1. Assalamu alaikum.